Pamela Archer. For you guys that know me, y'all know me as Pam. This is for my Trends and Issues class. It's called the Clinical Change Paper. It's based on a problem within this facility that needed to be changed or addressed. So in collaboration with Joanne, the Director of Nursing, issues that came to light were patient discharge wait times and just delayed discharges in general. So our Press Ganey scores, HCABs, whatever you want to call them, on the discharge wait times is where the lowest scoring was at. And I believe the question stated wait time from the time you were told you were going home, something to that effect. I don't remember the exact wording. And a lot of that comes into play because our physicians go see our patients, tell them, oh, you're going to go home. Then they go see the rest of their patients without putting orders in, without communicating to them. Maybe it's going to be after lunch. Maybe it's going to be in an hour. Give me an hour to get to do my part. It's hard to say exactly. I know from rounding with Sherry, when patients are going home, I try to make sure that they understand we're going to go around and then finish discharges. That being said, though, review of literature that I've done states that patient satisfaction scores increase when they are discharged before noon. The earlier the discharge, the happier they are. Number one, arrangement, transportation arrangement, maybe needing to go get their medications, trying to get family here maybe before a job or after a job. There's always those patients that will tell you I can't leave until 4 or 5 because I can't get a ride before then. But that is the rarity compared to what patients expect. Not only that, but because we service the 3 nursing homes around here, they want them early. So if we don't get our orders in until 12 or 1, and they want them by 2, if we can't get it done, then they just don't take them. Till the next day. So what happens, now we have a patient that has stayed another day. So we now have another loss of stay. Affects our reimbursement, affects revenue for the hospital in general, affects patient outcomes. The longer you keep them, the more prone they are to hospital-acquired infections, poorer outcomes, and we have to keep staff here. Rooms don't get cleaned on time. All of that plays into it. Not only that, but also in the literature it talks about, and we're small because so it doesn't affect us quite as much, but when we have capacity, when we have been at capacity, those delayed discharges affect your ER throughput, because if you have a patient or even coming from the clinic that needs to be admitted and we have a full house and we're waiting for discharges, now they can't get into their bed, so they're either being held in the ER, held out in the lobby until they can get a bed. So all literature says discharge, usually before 11, but discharge by noon is really the best case scenario. As I said, early morning discharges are associated with a significant increase on some of the literature I read for satisfaction. Plain and simple, patients were more satisfied when they could get out of here. We wouldn't be. The early mornings are decreased length of stay. Potential for increased revenue. Number one, you either don't get denied a day or 2 of the visit because they were here longer than they should have been, or facilities that can't take them because they waited too late in the day. And also it increases a culture of quality by taking care of those patients and getting them out earlier. That's on the discharge wait time. And the other potential problem is delayed discharges in general, which means patient should have went home today. We waited 2 days down the road, 3 days down the road. We didn't discharge them over the weekend when they should have went home. They come in on Monday. Now they're going to go home on Monday, and then the denials come. Well, we're going to pay for 3 days, but according to the record, on day 4, this patient was stable and should have been discharged on this day. So we're not going to pay you for 4, 5, and 6, or however many days it is. Loss of revenue. So by streamlining that, we can potentially cut down on that revenue, and as y'all know, because I write those appeals, I see it all the time. Again, in the literature, the physicians, some of the barriers that they talk about to early discharge, especially with the physicians, whatever. Poor communication, they cite poor communication with staff members, nursing, for the physicians that come in from other facilities, the discharge process varies from facility to facility. We don't have that big of an issue, except for maybe on the weekends with our ER docs, but most of them have been here long enough that they should know how to do that. Another barrier is getting an accepting facility. Maybe we're needing to send them somewhere and that facility can't take them. We've run into that on occasion. Some of those things are just stuff you obviously can't change anyway. And the other thing that the nursing staff cited as a problem was obviously not being notified in enough time to get those discharges out in a timely manner. Obviously, if physicians don't put an order in until 2 o'clock, then you can't get them out of here. And then again, the nursing homes or other facilities, rehab facilities or whatever, that want them early in the day ought not to take them until the next day. We keep them another day. So based on that, one of the final criteria for this project was to come up with some potential solutions to how to work the problem. I got three potential solutions. First and foremost is obviously better communication. That is an immediate action that can be taken without increasing money, without staff or anything, is better communication with the patient. Simply say, the physician simply stating, you're gonna go home today, but I'm gonna go see, whoever else, and I won't put those orders in until noon. Doesn't change the fact that we want them gone before noon, but at least it will help that patient who says, I was told I was going home and they're coming to the desk and I was told I'm going home and I'm not going home right now. They get their survey and they think, well, no, I didn't get to go home when I thought I was gonna be going home. So communication, that's a big issue, right now. The second potential, I read a couple of different articles. Well, I've actually read several articles and kind of compiled stuff and looked at two different things. So another solution that a hospital in maybe Chicago somewhere, they came up with something called a program called Discharges by 11. And they utilized a licensed professional as an expediter, what they called an expediter. That person met with the physicians, helped them prioritize who they should see first as far as getting them discharged. And then this facility, an expediter, because we're small, could actually, get those orders put in and get those patients out of here if physicians were willing. So that was one, and it worked real well with that facility. Might or might not, depending on your physicians. But anyway, helping them prioritize. This one wants to go home, you need to go see this one. This one is ready, go see this one. And another possible solution was interdisciplinary team huddles, first thing in the morning, not first thing, but early in the morning, and that could be between your charge nurse, your swing bed coordinators, behavioral health, if you have somebody going to behavioral health, case manager, whoever, where they get together and share the information. They know this one's ready to go home. We know this one maybe is going to go home. Charge nurses can state, we got report that this one's going to go home, and then you can use that huddle again for somebody to go and help those physicians expedite their process and get it moving a little bit faster. You could include your physician, nurses, assistants, Missy, or whoever. That particular one was done in a children's unit, probably not children's hospital, but a facility similar to that. And they actually increased their surveys by their positive surveys by almost 22%, just by somebody getting that physician to get those patients out by 11 o'clock, by noon, no later than noon, getting them out. Getting those orders in, helping nurses or whatever, get them gone. So those were the solutions that I found most relevant for this facility. There's lots of them out there, but for a small facility, those are really the only most relevant things that could possibly work for us. Questions?
Knowing our physicians and
Mhm.
our facility, which of those things do you think to be the most likely to succeed?
I think your expediter, because if you're gonna rely on your charge nurse, if she's busy that day to try to help expedite him, and you have your, you know, maybe that she's busy, got sick patients, then you kind of fall through the crack there. Because we really only have about 3 physicians that we work with on any given day. You know, you've got your hospitalist, you've got Dr. Tippin, and you've got Dr. Westwood. I think any of those would probably be accommodating under the right circumstances and the right presentation, and the right person helping them out. I think they would do that. I mean, it would be just like taking verbal orders. You know, you say you wanna go home, you went to see them, tell me what you want me to do, and let me go ahead and take care of that. Well, you go see the rest of your patients.
See, years ago, we used to do that with
Mhm.
Westwood,
Mhm.
because he
We
would tell
made
them, you're
rounds
gonna,
with
you're
Yes.
gonna go home, but I've got 5 more patients to see, and I've gotta do a scope before I put them orders in.
Exactly. And so therefore, the patient doesn't go home till
Right.
8 or
But
9,
they
you know.
that, so they don't start
Mhm.
counting, they don't start watching that clock until that time.
Right.
Exactly. I think, I mean, obviously communication is the first thing, because they just need to work on that, but I think if you were gonna look at one of the other two, I mean, the huddle is a good thing, obviously, but then again, like I said, you're relying, that particular facility relied on the charge
How do
nurse.
we get our hospitalist and 2 doctors on board?
That's the question right there.
And the weekend is a.
The weekend, you're gonna have
Yeah.
a problem with the weekend, because you're not gonna have a facilitator. I mean, you know, you're not gonna get somebody that's gonna facilitate that over the weekends. So I think you start with, during the week, we want to, and you set a goal, we want to increase our percentage of discharges by, you know, whatever percent in, 10
10
months.
You mean?
Yeah.
time
Yeah.
wise.
yeah, like, in 6 months, we wanna see an improvement of, you know, 2%, 5%, whatever you wanna do. And I don't know the percentages that we have right now, because I couldn't figure out how to run that report to see, what that percentage, where we stand currently. I just know from making rounds with being on the floor making rounds, that for the most part, patients don't get out of here until, and you know that too as a fact, until 2, 3, 4, 5 in the
Sometimes
afternoon.
it's shift
Yeah.
change.
And
Sometimes
they're
it's
on
shift
a
change.
schedule.
So therefore, you're keeping staff
Not
here.
calling and say, anybody go home now that we know of,
Yeah.
Right.
and then you come in the next day and 3 people went home.
That's exactly
Right.
right. So you're having to keep staff here. There again comes in the loss of revenue. The patients are staying, you know, later, and if they can't get out by the afternoon, now they're staying again another night, and we're gonna try to get them out the next morning. Loss of revenue there too, so.
I think this is important, and we need to work on it.
It is important, and like I said, I was glad in talking with you that this was something you wanted me to look at, because it is very enlightening and eye-opening, especially when you read the literature and you see all of the literature that states discharge before 11 is better for patient outcomes, HCAP scores, all of that. So, it was enlightening, it really was, and like I said, I think it's something we need to further investigate and look into,
Yeah, I'd like to work on that.
and see what we can come up with. I think,
Try the other door.
I think that it's something, you know, I think and when you, and talk with, you know, get Mr. McCoy involved in whatever they decide to say, okay, we're gonna set a goal, we want, you know, those doctors are competitive,
Yeah.
That's right.
they're competitive, all of them, I'm telling you.
Well, you know, how did we fix times in that scope room? By
Yeah.
showing every doctor
How long it
takes
took, and they
every
fixed
other
it, yeah.
doctor to get started.
Yeah.
Right.
So that,
And so therefore, when one saw that this one was doing better than me, they're gonna change their ways.
And
Right.
that's probably a place to start with this,
Yeah,
you know.
you have to play on that competitiveness that they have to see if
But
you
I
can.
get a lot of Granny complaints about, I was told at 9 o'clock in the morning I was going home and I didn't get out of here till 2.
2
Yeah.
or 3, you're right.
Exactly.
And then I get things that say the nurse that was
14.
discharging was rude and short.